this is the last session of today, day 2, session number 7. The topic is food allergy, and Dr. Mohammad Mikdady from UAE is the speaker, and he is a very renowned and looking very young and handsome. He is an American board certified in pediatric gastroenterology. He is currently the division chief pediatric gastroenterology at Sheikh Khalifa Medical City in UAE, Abu Dhabi. He is also the clinical professor at Khalifa University, UAE. So the topic is food allergy. So I will request our speaker, Dr. Mohammad Mikdady, to give the lecture about their topic, food allergy. Thank you.
Thank you, Dr. Nator, for this nice introduction. Trust me, I'm not young, and I don't think I'm handsome either. Probably I'm many years older than you. But thank you for the nice introduction, and good evening to our colleagues in India and in Chennai, India in specific. I miss the visit to Chennai and meeting my very wonderful friends over there. So, ladies and gentlemen, over the coming 20 minutes, I'll be talking to you about the food allergies and the aspects of food allergies in the 21st century. And I will shed some light about the food allergies and what I believe to be the relationship with food allergies and COVID and the era post COVID as well. All right. I'm just gonna wait for my screen to work. Yes. So I will talk about 3 main points: the burden of the allergic disorders. Then we'll talk about the clinical features of food allergies, and specifically cow's milk protein allergies. We'll talk about the IgE and the non-IgE, and then I will shed some light on the different aspects in the management of food allergies, and specifically cow's milk protein allergy. Let me ask you some questions, and I will have the time at the end of my presentation to see what you think about the following statements. Do you believe at the time of the COVID and the lockdown, social distancing may increase the risk of allergies? And if you agree or if you disagree, just think about the causes that it might be related to the prevalence of allergies. And then I want to ask you about, does the lockdown also affect the allergies, like the social distancing? And then the third point, the use of PPEs might decrease or increase the risk of latex allergies among healthcare workers. And I'm sure many of us are using many of their PPEs. And the fourth point I want you to think about it is the use of disinfectants and sanitizer. Does it disturb the human microbiome? So think about these 4 points while I'm giving my presentation. The burden of the disease is probably significant for 4 different reasons. The first reason, there is a rise in the prevalence of the disease of food allergies all over the world, whether that was in the developing or in the developed countries. And I'm sure in your practice, you notice there is an increased risk of allergies. As you all know, the allergies are most common during infancy, and among that, the commonest is cow's milk protein allergy as the leading cause. The EU have estimated that 50% of all Europeans will suffer from allergy by the year 2025. And that's not taking into consideration the COVID and the pandemic that we are living through. And I feel with this pandemic, probably the risk of allergies will be even much higher. The other aspect of the burden of the disease, that allergies have become the most common chronic disease. And I'm talking about different kinds of allergies, whether it's an upper respiratory allergies like allergic rhinitis, or I'm talking about allergic conjunctivitis, sinusitis, lower respiratory like asthma, skin allergies, as well as food allergies. And please remember that in infancy, the commonest allergy again is cow's milk protein allergy. The third aspect of this increased burden of the disease is actually that the disease is becoming more and more aggressive disease. Not only the incidence and prevalence are more, but we notice that the severity of the disease more. As you can see to the right hand of the slide, it's the increasing number of hospitalization of these patients, and this particular study was done in Italy. Moreover, we are seeing that the disease now persists after the usual age. For example, we usually say cow's milk protein allergy disappears by the age of 5 years of age. Now we are seeing cow's milk protein allergy even continuing into school age. The fourth aspect of the burden of this disease is actually affecting the quality of life. We know that patients who have allergies, they are at more risk of developing non-communicable diseases in the future, like diabetes, hypertension, and heart disease, and so on and so forth. Also, there is a psychological aspects to these patients affecting their life and the quality of their life if they keep being teased about, for example, their dry skin or their chronic cough, and so on and so forth. That might affect their social status and may lead to some social isolation in these patients. There is also a financial burden to the parents if they have to go and see different doctors seeking consultations, or if they have to pay for certain tests or special kind of foods, and so forth. So, what are the strong influencer of the disease? Actually, genetics is probably the strongest influencer. As you can see in this diagram, if none of your parents have atopy, your risk of allergy is about 5 to 15%. Let's say 10%. So 10% is a high, given the fact that none of your parents have any atopic disorder. But this risk actually will increase, obviously, if you have one parent who have some atopic disorder, and the risk will reach anywhere between 20 and 40%, which is a big jump. If you have one sibling with atopy, again, the risk is 25, 35%. If you have both parents are atopic, the father and the mother both are atopic, the risk will jump even up to 60%. And if both of them are allergic or atopic with the same kind of disease, the risk will reach up to 80%. So as you can see, with increasing family history of atopy, your risk of developing an allergic disorder increases in an expansional way. And even if you don't have any family history of allergy, your risk is not zero, it's actually 10% or so. This is the allergic march, and I'm sure many of you are very, very familiar with this allergic march. The allergic march, what it says, it tells you the different manifestations of allergic disorders at different age groups. If you look at the x-axis is the age in years, and the y-axis is the prevalence of different allergic disorders. As you can see, when you are young, okay, when you are young, you are more likely to have GI disorders as well as eczema disorders. So skin and GI when you are younger. And when you get to be older, you have more respiratory illnesses, whether it's an upper respiratory like allergic rhinitis or lower respiratory like asthma disorder. What I learned from this allergic march actually is several things. First of all, if you see a young child here with a skin or GI disease, you can tell them more likely when he gets older, he's going to develop some respiratory allergies. And vice versa. If you see a teenager with asthma, he's more likely when he was younger, he had some eczema or have some GI disorders. More importantly than that, this window of opportunity here early in life, maybe it's a window of opportunity for intervention. If we can prevent GI allergies and skin allergies here, we may be able to prevent respiratory allergies when you become older. So let's move on to talk about the clinical features of the cow's milk protein allergy, whether it's an IgE or non-IgE. This is a publication that I co-authored with several of my colleagues, and in this publication, we talked about the consensus statement in the prevention, diagnosis, and management of cow's milk protein allergy. Although this was developed for the Middle East, but I'm sure many aspects of it can be applied to our patients in India as well, since we have a lot in common. The first thing is the IgE manifested, or the type 1, or the anaphylactic or the immediate allergic reaction. In this kind of patients, they develop anaphylactic reaction with all the features of anaphylaxis early on, and one of that is actually what's called the F5, which is the food protein-induced enterocolitis syndrome. Typically, it happens almost immediately. Sometimes it might lag behind for an hour or so, but that's the max. And these patients, they are very sick, as you can see in this picture. He has swollen lips and probably have developed some skin rash, if you can appreciate it here. And it's very likely that this patient will have some respiratory problems, usually in the forms of stridor or wheezes, or even hypotension from vasodilatation. And the GI manifestations of cow's milk protein allergy, it can be either in the gastrointestinal tract, it can be in the cutaneous, like in the skin, which is like 20 to 40%, or respiratory symptoms, like up to 25% of these infants. And sometimes, unless you dig in the history looking for this, you might not pick it up very easily. I will show you some of these common presentations. The non-IgE usually happens in the background of a family history of allergy, atopy in a sibling or a parent. Usually more than one organ is involved, like the GI, the respiratory, the skin, and so on and so forth. And usually the symptoms, they don't respond to the classic treatment. What I mean by that, like if you have a patient with reflux, you treat them the way you treat reflux and they don't respond to the anti-reflux treatment. This tells you that this is probably or could be an allergic manifestation of the cow's milk protein. This is the table from our publication. Let me get it one by one. Starting by the GI tract. The GI tract manifestations of allergic disorder, it's very so non-specific. It can be anything from abdominal pain to vomiting to diarrhea, dysphagia, vomiting, sometimes even constipation, in the severe cases, failure to thrive, anorexia, and so on and so forth. So the symptoms are typically not specific. And this would explain, at least in part, the delay in the diagnosis of cow's milk protein allergy in these patients. And here, as you can see, all these kind of symptoms are under the umbrella of GI manifestations of cow's milk protein allergy. Again, none of these symptoms are specific to that. And obviously, all these symptoms can be caused by other organic disorders. However, having said that, the classical or the stereotyped presentation of GI manifestations of cow's milk protein allergy can be divided into two categories. The enterocolitis, which is the large intestine disease, and the small bowel disease, which is the enteropathy. Okay, I can skip that. The enterocolitis is probably the commonest presentation and the easiest to diagnose. Typically, this child starting having some infant formula sometime early in infancy, but the symptoms do not develop immediately. Usually they develop around the age of 2 months or toward the end of the second month of life. The mother will describe to you the passage of stool with a small amount of blood there, like a streaks or dots of blood there. So mucus with that, although that's not necessarily the case always. The child might be fussy or cranky, and usually they do not have diarrhea, although the mother will describe a more frequent stools, sometimes a little bit softer stool, but no frank diarrhea. I picked this picture for you from my mobile. I'm sure all the pediatricians in the group, they have their patients sending pictures like this. You can see this is a soft stool, and you can see there's some reddish discoloration here. This is suggestive of the enterocolitis or the allergic colitis picture. If you see such a picture in the right context, i.e. positive family history of atopy, a patient who is formula fed, I bet you this is cow's milk protein allergy, and most societies will suggest to go ahead and start empirical treatment. Rarely you have to do any confirmatory test. If you have to do any test, you might do a flexible sigmoidoscopy, and these patients, they will have some kind of colitis with some erythema change in the usual characters of the chronic mucosa. If you biopsy it, you will see a lot of eosinophils there. But again, it's unlikely that we have to do this kind of study. In my practice, probably I would see 100 patients with this picture. I'll treat them empirically, except one patient who might need a flexible sigmoidoscopy. This is the histology of a normal, beautiful colon, and this is the histology of an inflamed colon. All these pink little dots here are probably eosinophils, and when you see a collection of them, it looks like probably an eosinophilic abscess. So that's the commonest. The less common is the enteropathy, which is a small bowel disease, and these patients, they come with diarrhea, sometimes vomiting, failure to thrive, and the albumin might be low. So it looks like a small bowel disease. It looks like a celiac disease, although these patients are not exposed to gluten, so it cannot be celiac, but a celiac-like picture. Again, you can diagnose them empirically, but if you have to do endoscopy, the biopsies, they look with villus atrophy and cellular infiltrate, that is suggestive of the allergy. The skin manifestations, they can be anywhere between a dry skin to a florid eczema, urticaria, angioedema, and so on and so forth. And sometimes it can be subtle, like just small patches of eczema on the face. Respiratory manifestations, they can be anywhere from runny nose to stridor to cough, chronic cough, or wheezes, and so on and so forth. How to differentiate between infectious versus allergic disorder? There's a few tips that might help you. If this is out of the season, if you get these symptoms in the summer, usually we see viruses more in the winter. If the symptoms do not respond to the usual treatment with beta-2, Ventolin and others, or if you give them steroids and they don't respond and so forth, you might consider allergic disorder. Okay. So let's move into the management, and I think we are right on track on time. As you all know, the hydrolyzed infant protein formulas, they can come into 3 degrees of hydrolysis. Either the partially hydrolyzed, if you hydrolyze it more, it becomes extensively hydrolyzed, and if you chop it more down to an amino acid, it becomes down to a 3 amino acid formula. So this is the intact protein, this is the standard formula or the breast milk, this is the partially hydrolyzed, this is the extensively hydrolyzed, and you can see here, this is the amino acid formula. The partially hydrolyzed are being marketed as HA, so formula X, HA. So as you go from your left to your right, this is the most allergenic, less allergenic, even less allergenic, and not allergenic at all. The tolerance, this is the best tolerance, and as you move down, this is less tolerance, less and less tolerance. Of course, you like your patient to have more tolerance to that. The taste, this is the better tasting formula, this is less tasty, this is not tasty, and this one is not tasty at all. Of course, the price, when you go from intact protein to HA to extensively to amino acid formula, the price goes higher. What you can get from this slide, to move on from an intact to HA to extensively hydrolyzed to an amino acid formula, you should have a good reason, because although it's less allergenic, but it's less induction of tolerance, it's less tasty, and it's more expensive. All right, the partially hydrolyzed can be used for prevention, while the extensively hydrolyzed and the amino acid formulas can be used for treatment. Keep in mind that all the extensively hydrolyzed and all the amino acid formulas are lactose-free by default, by the way of manufacturing. In this graph, this is again from our Middle East publication. It talks about the management algorithm. Very easy to follow. It's good for a busy pediatrician. If you have somebody with anaphylactic reaction and he's not being breastfed, so you have to give him an amino acid formula till the age of 1 year. If it's not anaphylactic reaction, if it's a non-IgE type, of course, you can do the blood test or the skin prick test, and we can talk about this in a different situation. These patients, they probably will respond to an extensively hydrolyzed formula, although some of these patients, they might not respond to an extensively hydrolyzed, and they might need to use an amino acid formula. Whatever you treat these patients with, the treatment is in general till they reach the age of 1 year. Hopefully by that time they'll outgrow their allergies. But again, some of these patients, they might continue to have allergies even after the age of 1 year, and that's estimated to be 20% more or less. All right, I'm going to skip these for the interest of time. The gut microbiota. I mean, you cannot discuss allergies in the 21st century without talking about the gut microbiota. As you can see to the left side of the slide, infants who are healthy, they have a healthier stool microbiota, while patients who have allergies, they have a dysbiosis, imbalance in their bacterial content there. Whether that's the cause or the effect, I think that's an area of debate, and probably we can spend hours talking about this and its role in prevention or in treatment. So, ladies and gentlemen, I'd like to conclude by leaving you with some important take-home messages. The first one, there is an increased prevalence of the disease in the developed and in the developing countries as well. It has a huge burden on the health, the quality of life, as well as the economy of the individuals or the society. The best predictor for atopy is actually a family history of atopy. The manifestations, they can be in the gastrointestinal tract, they can also be in the skin, or can be in the respiratory system. The management, if they are breastfeeding, probably the best thing you can offer them to continue breastfeeding and avoid cow's milk or mammalian milk intake. If they are not breastfed, then extensively hydrolyzed formulas till the age of 1 year, and amino acid formula can be used if the extensively hydrolyzed have failed, or if there is severity of the disease like anaphylactic reaction or failure to thrive or severe symptoms. So, Mr. Chairman, I'd like to try to answer the first question that I have in this presentation. Does social distancing increase the risk of allergy? Possibly true. And this is an extrapolation from all the studies that have shown, for example, if the bigger the household, the lower risk of allergies. So if somebody has like 3 brothers or sisters, they are less likely to develop allergies than if somebody is the only child for the family. So social distancing in a way similar to that. Lockdown will increase the risk of allergy, probably true, because of the hygiene theory. Dr. Natwar, the hygiene theory tells you if you are exposed to an antigen early in life, you become tolerant, and if you are not exposed, you might get allergies later on. During lockdown, we were less exposed to all these allergies. Use of PPE probably will increase your risk of latex allergy. This is what's shown, that people who use more latex gloves are more likely to develop latex allergies later on. So I bet you we will see an increase of latex allergy later on. The use of disinfectant does affect the human microbiota? Very possible. We all know that the microbiota in our skin, GI, respiratory, genital, urinary tract, it's huge, and the use of these disinfectants will kill all these good bacteria, and probably our microbiota will be different. Thank you very much, and wish you a beautiful and enjoy the conference, and hope to see you face to face in the near future.
Thank you very much, Professor Mohammad McDaddy, for this wonderful and crisp talk on food allergy. It's really a wonderful talk, and we all definitely will enjoy this talk, and will definitely learn a lot of things from this talk. Thank you so much.